Thank you, Jeff. Just a correction for the first slide. My co-author is not Riopando, it should be Samaniego. And she's been working with Jeffrey for a long time for this PCAT work. Okay, so I'll be sharing with you what we're doing in the Philippines in terms of PCAT. We would say that we're a late bloomer. I have seen that Hong Kong and Korea started way back 2007, but we only started in 2010. Jeff has given this to us, and we subscribe to this definition in the Philippines. And in the Philippines, we use primary care and family medicine interchangeably. And this was also given to us by Jeff earlier. So the objectives of my presentation is to describe the PAP initiatives. PAP is the Philippine Academy of Family Physicians on PCAT. I'll share with you some of the accomplishments and then present recommendations on how we can enhance PCAT in the Philippines and probably also in the Asia-Pacific region. So in 2010, as Jeffrey has said, we had a workshop on, it's a little international summit in Asia-Pacific with workshop on primary care assessment, and this was in January. And we had representatives from Vietnam, the Philippines, Indonesia, and Malaysia. And then after that workshop, the Academy had the 5th Strategic Planning Workshop. We do this every 5 years. We have plans, and then we review our plans, we monitor, we evaluate, and then at the end of 5 years, we come together again and make another plan. And in this particular plan, we have identified that the PAP and its components, chapters, or accredited departments should engage in PCAT researches. And why is this so? Because we believe that in the Philippines, we need to convince a lot of policymakers that the entry point, that the physicians at the entry point of care should be family physicians, trained family physicians. But to do this also, we will need to show evidences that the care that is being given by a trained family physician is better than those with no training. And then in 2011, during the 18th WONCA Asia Pacific Regional Conference, which is also the 10th World Conference of the WONCA Rural Health, was held in Cebu, and there were 6 sessions on PCAT organized with Professor Barbara Starfield and Jeffrey and Abby. And then in 2012, we had a workshop on enhancing universal health care through strong primary care, because in that year, the Philippine Health Insurance Corporation had made an announcement that primary care benefits will be made available at the outpatient for all families who will be registered. So this is in line with the Aquino Health Agenda that universal health care will be the priority project of the health department, and the implementing arm will be the National Health Insurance Corporation. So we had a workshop with them, and we tried to convince PhilHealth that the best thing they can do is to make sure that this is anchored on strong primary care through family medicine. And in that workshop, we have agreed that we're going to show PhilHealth, the policymakers, that the care that's being given is much better, and we are going to use the PCAT tools. So in the January 2010 summit, we had an orientation on primary care study and PCAT models by Jeffrey, and we agreed to have research using PCAT to be presented in Cebu in 2011. And we did have presentation from Korea, although they were not in the workshop, from Indonesia and from the Philippines. So in Cebu, we had a 2-day workshop, 6 sessions. And the workshop was developed to email exchanges between Dr. Samaniego, Jeffrey, and Professor Barbara Starfield. And during that conference, we had 6 sessions dedicated to PCAT. There were lectures on utilization of PCAT internationally, and we had presentation from Asia Pacific, the Philippines, Hong Kong, Korea, and Indonesia. And there was a lecture on PCAT systems and its relevance to Asia Pacific region, and a core consideration is that PCAT will be followed up, and will be used. We also had workshops on how to improve service delivery to make it more how to improve the application of PCAT to make it more country specific. And also we identified the coordinators from each country, and it was agreed that we will be preparing proposals so that PCAT can be used. PCAT, the health system component, can be used in the different Asian countries. But as Jeff has said, unfortunately, 4 months after, Professor Starfield passed away. And in the Philippines, there was somewhat slowing down on PCAT activities because Dr. Samaniego was the key person in the PCAT, also had ceased to be the chair of the research committee because he had his mandatory rest as member of the board. However, we were able to have 10 researches, and only 2 were published. I really admire Hong Kong and Korea, because they made sure that their studies are published in the journals. So the first one is the linguistic validation of PCAT in 3 languages. The Philippines has more than 120 languages. So it's really not easy to come up with PCAT, to make use of PCAT unless we're able to translate them. And we only chose 3 languages, Cebuano, the Tagalog, and Ilocano, which we can say are the major languages of the 120. So what were the findings in the linguist? We had translation back translation, and the comments that they have is that the tool is too lengthy. It's difficult to administer if it is self-administered, because definitely the ones who are answering will need guidance. And then there are some issues that are not relevant to the Philippine setting. So the recommendation is that we shorten it, we simplify, and before it is applied. And then the other ones I will be mentioning later. But this one, the latest that was done, is revisiting the performance of primary care at the hospital ng Manila Medical Center. It didn't make use of PCAT, but instead it made use of the 4 domains: the first contact, and the continuing use, the coordination, and comprehensiveness. And they just reviewed the census for 2 years, 10,000 patients in one, 8,000 patients in the next, and they were able to show that there are areas of improvement to be done in the way primary care is delivered in the hospital. So you will notice here that majority of the studies were done in hospital setting. And we are hoping that we will be able to do more studies in community-based primary care facilities, which is where primary care services are really being given. So here we have the measurement of the primary care performance of the Manila Health Cluster. Manila is the biggest city in the Philippines, and it has 200 healthcare centers, and they focus the study in some sites. And the objective was to assess services in primary care facilities using core and derivative domains. And the findings were that the health centers got good scores in coordination of care, family-centeredness, ongoing care, and information system. But they need improvement in terms of cultural orientation and access. So the recommendation is improvement through training of primary care physicians and keeping community lines open. The next study was done in our hospital and 8 others. So this is mainly in training programs. And the survey used was that of providers. So the first one is facility and the second one is provider survey. And all were short version. So the objective was to determine primary care orientation of different training programs. And the training programs get very good scores in terms of coordination, information system, family-centeredness, cultural competence, but needs improvement in terms of availability of services and ongoing care. This is so because the services are not on 24-hour basis. Phone calls is not yet done regularly in the Philippines. Okay? And the recommendation is to provide residents greater exposure to outpatient rotation and community clinics. Although we require in our standards that if you have a 3-year program, 18 months should be spent in outpatient facility of the Department of Family Medicine, and each one should have a community-based program where you hold clinics, but in addition to holding clinics, you're supposed to have been organizing the community and the people in the areas. The next is a multi-center study of primary care services rendered to Northern Luzon. The first 2 were the only ones published. The next researches I'm going to present have not been published. This was done in Pangasinan, in 2 government, and 1 private hospital and 1 private clinic. Here, the objective is to evaluate the adequacy, field validate PCAT, and assess the extent and adequacy of delivery of primary care. But I have some problems with the scores, and I didn't have time to talk with the patients because they had a frequency for the 5 instead of computing for the average, because we have 3.5 as the passing rate. So this will need to be rewritten. But they reported good scores in the extent of affiliation, first contact utilization and access, continuity, comprehensiveness, family orientation, and cultural competence. But needs improvement in availability and access to health records and community orientation. The next is a survey on adequacy of primary care in HMO patients seen at the hospital. HMO is the Health Maintenance Organization. In the Philippines, we have health maintenance organizations affiliated to the different hospitals. And usually, the HMO in the hospitals have family physicians as the doctor's coordinator. So they use PCAT Consumer Client Survey, and they evaluated the adequacy of primary care among HMO patients, and they got good scores in contact affiliation, ongoing care, coordination, culturally competent, but they need improvement in terms of community orientation. They had the notion that community orientation is related to home visits. It should not be the case. No. It's not all the time only home visits. And the next is, in 2012, comparing primary care performance of 2 hospitals. Is 1 hospital in Manila and the other in Cebu. 1 is government and the other is private. They compared primary care performance of 2 outpatient clinics, both under the Department of Family and Community Medicine. Both passed the PCAT scores, the average, but if you look at the different items individually, there's higher score in Manila for first contact utilization, ongoing care, family-centeredness, and coordination. But both needs improvement in comprehensiveness, first contact care, community orientation, cultural competence. Recommendation: with universal health care, we need deeper scrutiny of the way we are giving primary care service to the Filipinos. The next is community patients on the adequacy of primary care service. This again in the same hospital, we have the HMO, and they made a study in the adapted clinic, and using the validated Tagalog version to determine the adequacy of the primary care services. They got good scores in first contact utilization, coordination, comprehensiveness, and family-centeredness. It needs improvement on the extent of affiliation with a place or doctor, first contact access, coordination, and culturally competent. So the recommendation is to use PCAT in other primary care services handled by that same hospital. The ninth is the study on the quality of primary care services rendered among adult patients of the FCM and outpatient department. So this is the response to the recommendation from the same hospital. So they use PCAT and they use the outpatient clinic to determine the quality and adequacy of primary care services. So they got good score in first contact utilization, ongoing care, coordination, family-centeredness, and cultural competence. Needs improvement in community orientation, comprehensiveness, comparison of scores with social demographics. So you will see that practically in most of these studies, they have the same good scores. First contact utilization, ongoing care, coordination, and family-centeredness. And this is so because in our training programs, we're very heavy on looking at the family context in terms of care. The last paper which was presented in our convention was the validation of Tagalog version of CAT. This is the child short version, and this was not done in family medicine but in pediatrics, but the study was conducted by the staff of the Department of Family Medicine, and the parents were the ones who were asked to fill out the questionnaires, and they determined the reliability and validity of the Tagalog version of the PCAT child component. And they showed excellent reliability with Provac alpha coefficient of 0.91. The measurements has content, concurrent, and construct validity. So, what are our recommended plans? One is, I think, as we have seen from the reports of Korea and Hong Kong, we really need to have a group within the Philippines who will focus on PCAT. And this is very important because of the changes that is happening. We now have primary care benefits being offered to all the Filipinos. We now have family registration. Filipinos will have to be registered by families with the National Health Insurance Program for them to avail of primary care benefits. And there's now gatekeeping mechanism that has been introduced, meaning to say that all patients will have to go to the primary care facility where they are registered for them to be evaluated, and it's the primary care physician there who will make decision whether that particular patient will need referral or not. So it's really very important that we're able to assess the kind of service that we give in primary care in the Philippines. And in addition, the Philippine Academy is working closely with the Philippine Health Insurance Corporation. In fact, right now, only government hospitals, the outpatient departments of government hospitals can apply to be a primary care provider. But there's a memorandum of agreement between PhilHealth and the Academy that all accredited programs can apply to be provider of primary care benefits. So it's really very important that we are monitoring the way we're giving primary care services to these registered families to the primary care facilities. And in addition, the Department of Health also organized the Family Medicine Residency Training Program, making sure that the municipal health officers or the government physicians in the health centers will be trained in family medicine. So we need all these studies so that we can show to the policymakers that indeed if you have trained family physicians in the primary care facilities, the primary care services will be much better. So we hope we'll do more PCAT studies in support of primary care as key to the success of universal health care. And it's not just how we're doing it now, because right now, we only have 4 hospitals involved. We have 60 chapters, 58 programs, so we need to really have this core group who will do the PCAT studies in various centers. We make comparative studies between trained family physicians and those without training, their primary care performance, because we, unlike Vietnam, for example, they already have a policy that the family physicians should be, that the doctors in the community health centers should be trained in family medicine. Indonesia also has that policy now that the doctors at the health center, which will be the entry point of care, should be trained in primary care or further trained in family medicine. And in Vietnam, in Thailand also, the primary care unit, the physician should preferably be a family physician. So we hope we can have that official document which will require all those at the entry point to be trained in family medicine. Because all of these are implied, not really a policy yet. So we submit policy recommendations that the need to train physicians in family medicine at the entry point of care. And whatever findings we have, we should have a concerted effort to improve the services as needed. And we need to have more adequate monitoring. Okay? And as Jeff has said, we do hope that we will be able to revive the plan to have this collaborative work on the evaluation or assessment of primary care services in the different countries in Asia Pacific region. Thank you very much.